As folks make their way back from the break, I just want to take a moment to say thank you again to our sponsors, AstraZeneca, and for academic investigators, faculty. We often sort of think about, the work that we do within the context of an academic health system and with our community partners. But we really do have a broad community, and I've been so thrilled to be able to partner with my colleagues from AstraZeneca because, it's the public-private partnerships are so critical to addressing lung cancer equity, but lung cancer equity in particular. So as I mentioned, we're now going to hear from Trish McDade O'Neill, who is the Director of Corporate and State Government Affairs for AstraZeneca's West Coast region. She has extensive expertise in biopharmaceutical advocacy, where she shapes and excels in shaping public policy, leading state-based lobbying campaigns, and forging state alliances. And she's joined by Brooke Bernal, who is the U.S. Oncology Inclusion, Diversity, and Health Equity Lead at AstraZeneca. She's an accomplished, award-winning business professional with exceptional talent in developing and executing enterprise-wide patient access solutions. So I'm really excited for what they'll share with us today because we have lots of lessons to learn from their expertise. So thank you so much for sponsoring our event today and for joining our panel. Thank you.
Good afternoon, everyone. Okay. So before we really dive in, there's just a few things that I wanted to highlight. The health ecosystem is quite complex, as we know, and so is pharma, is the reality. Just like every organization out there, we have our silos too. And so I say this because this really sets the stage for this program for our organization. And so we have our own barriers that we have to overcome. The interesting thing, though, is that AstraZeneca is a lung health company. I like to joke that we cover the lungs from A to Z. However, this is the first time that we actually came together with two business units and said, let's do something together and let's make a true impact. So when I stepped into my role last year, it was a personal goal of mine to actually try to take down some of these silos that we have. And it was important that we figured out how to better connect our chronic care network to our cancer work that we're doing. And so that's exactly what this program, Lung Health United, is about. So I will say I did chuckle when Dr. Cummings said you can't boil the ocean, and that's exactly how this program can feel at times, is you want to do everything, you want to do it on a grand scale, but the reality is you can't, because it's really hard to measure it when you're doing it from such a large scale. So I'll talk about how we're actually implementing this at more of a local scale. But so what is Lung Health Unified? So it's an integrated approach to lung disease. It recognizes the shared risks, pathways, and solutions across lung disease. However, we decided to make sure that we started off focusing on cancer and COPD. So through the integrated approach, we wanted to close those care gaps across the lung health journey. So through earlier detection, guideline-directed care, and enable equitable access across communities. So those are the three sort of pillars that we are focusing on when it comes to Lung Health Unified. So why does it matter? We get this question a lot, like, why not asthma? Why just COPD and lung cancer? Again, can't boil the ocean. We had to focus. And so that's why we really started here. So lung cancer drives cancer mortality, but screening rates remain low. We've, I think, beaten this to death today, unfortunately, bad pun. But we've talked about this consistently, where there is such a great opportunity in the lung cancer space. Early detection changes survival. So we know 5-year survival rates reach 64% when lung cancer is detected early, compared to 27% overall. Also, COPD affects millions. Right now, it's within the 5 leading causes of death and consistently growing as we have an aging population. Guideline-directed care remains underused. Only 25 to 30% of people with COPD receive guideline-directed therapy. And I think we mentioned a lot of times what we see is patients use emergency rooms as their primary care. So they're also not having that continued care and follow-up afterwards to see if they're actually eligible to move on to guideline-directed care. And then lastly, disparities widen the impact. So in the work I do, I've been focusing a lot on rural communities because as we've seen with some of the changes that have happened in the last year, rural communities are being impacted most greatly. We're seeing hospitals shutting down. We're seeing an overburden in the physicians for them. There's a high burnout rate. And also they're not getting the information they need to stay on top of the innovative therapies that are coming out. So it's important that we especially focus on the rural areas because they need that love right now. Okay, so why we look across lung cancer and COPD. Again, we talked about silos, right? There's silos everywhere. When I came from actually the pulmonology space before I stepped into the cancer space last year. So I'd worked in pulmonology for the last 8 years, in COPD and not lung cancer, in asthma predominantly. And what we found is that it was really the primary care space that was most important to lean into. They have a very difficult job because it's, hopefully they have their patients coming to them for their annual visits, but that's not always the reality. But they are sort of that entry point, if you will, to the specialists. And that's the most important place that we have to start is actually educating the primary care physicians on what are the risks in lung cancer? What are the COPD guidelines? Because a lot of times they are the ones who are saying, hey, let's get you to that next line, whether it's lung cancer screening, whether it's get you on therapy for COPD, or hey, let's actually find you a pulmonologist, hopefully close by that you can actually see to get better care. COPD signals elevated cancer risk. So individuals with COPD are 2 to 6 times higher risk of developing lung cancer. So these patients should be looked at and screened and focused on, especially when it comes to lung cancer screening. And then we did see that overlap. So 30 to 40% of lung cancer patients have COPD, but often is undiagnosed. So again, we have a missed opportunity in connecting that care. Okay, so what is AstraZeneca doing? We're doing a lot. However, again, as we went through this process of saying, what is it we're gonna do in lung health, we actually were doing things, again, in silos in different places. And so myself and a few of my colleagues said, we need to collate everything we're doing and actually say, okay, what is it we're doing? Are we putting the chips in the right place? Are we leaning too heavily in one area? So this is really the work of what we're doing that helps shape us in how we deliver on certain tactics. So the first is integrated lung health pathways. So we're supporting health systems in linking lung cancer screening workflows with COPD risk identification, referral, and follow-up. We also do early detection and diagnostic support. So we talked about AI, we talked about different types of technology. This is an opportunity for us. We get a lot of tech companies coming to pharma and saying, hey, look at this cool tool. And we're like, awesome, did you show the health system? Because it's really gonna benefit them. So it's an opportunity for us to actually be the connector between the two and also say, okay, what programs can we maybe pilot and see if they actually would work with the health systems? Rural and underserved community engagement. So again, this is supporting community-based models. Again, going back to that localized model. We do some great work. We have some great grants at a federal level. But really where that work really, the rubber meets the road, if you will, is in the local communities. And that was exhibited here today. All of your programs that are done at a local level have significant impact. And so for us, we decided that we were gonna focus in 5 states. So California is one of them. There's Texas, Florida, Maryland, and Kentucky. And so right now we focus our programs and our partnerships in those states because we want to measure impact in those states to start. And I'll have Trish talk about what we're doing here in the state of California. But right now we're focusing our attention, and especially when it comes to that health equity lens, we're looking at it through a rural lens because that's where there's that greatest need we found. And then lastly, policy and systems collaboration. So we work with patient organizations, healthcare providers, policymakers to reduce the administrative and affordability burden in our healthcare space. Okay, this is a very busy slide, and I'm not gonna read it all. But when we actually talk to all of our different ecosystem partners, it's important that we have a specific call to action. So we have different calls to action for each group. So healthcare practitioners, for example, it's how do we optimize guideline-directed COPD treatment? For policymakers, it could be how do we improve access to healthcare and treatment or eliminate cost sharing and prior authorizations? I would love if we could eliminate prior authorizations, but that's just not really gonna happen, I don't think. Maybe in 5 years, we'll see. Health systems, how can we integrate lung care pathways, embed cancer and COPD prompts into workflows? From what I've heard today, a lot of you are already starting to do that, which is great, which also, helps identify things earlier. And then lastly, when it comes to guideline and quality leaders, how can we expand that cancer screening eligibility? I love hearing how we need to look beyond just the smokers. We really need to see who else is truly eligible. How can we identify those populations and then go to legislators saying, how do we open up care for all? We were talking about recently, could we do something like what we do with mammograms or colon cancer where it's age-based? So that in age-based and saying, lung health, can we do a lung health screening? Is there something like that we can do to truly improve lung health overall? So these are our call to actions that when we talk to each different group, we'll be focusing our attention in those spaces. Okay, so now I'm going to hand it over to Trish to talk about California.
Thank you.
Yeah.
Right on. Hey, thank you, Brooke. Well, hello, everyone. Nice to see a lot of friendly faces and folks that I've gotten a chance to meet and work with. And as Brooke mentioned, we're kind of coming together and really focusing on our lung health strategy, but it's really about aligning with the organizations that already are in this space. And my role in state government affairs is to sort of pull through some of our community engagement, work and align on policies and with groups that we have aligned interests and aligned mission. And so I wanted just to focus a little bit on the work that has been lifted up through Healthy Lungs California. So we kind of plug in on how can we support the policy and advocacy arm, the vision and pillar underneath Healthy Lungs California. And that was sort of in discussion with Dr. Cummings and Shanita about that vision of really developing an aligned policy and advocacy agenda and delivering on some results that we can pull through statewide. We are supportive of that effort. And, as a partner organization, we want to try to provide a venue, provide an opportunity to bring together partners so that we can share that voice, create that momentum. And not only on lung cancer, as Brooke has mentioned, but we really want to weave in the importance of lung health in general. So our focus is not only partnering on advocacy efforts with health systems and provider groups and pharmacists, and a call out from last year, I remember, and really focusing on how we can share on driving the agenda that really helps improve access to patients and getting the care they need. And sometimes that's not intuitive. It's just a matter of really making sure that we can pull through what is of most interest to our partners. And that's where we can help amplify that information in networking. To do that, one of the specific agendas is that we're looking at policies that we can kind of shape and amplify the great work that the American Cancer Society has already done in shaping in the work with the American Lung Association and all partners with the Healthy Lungs California is for example, the Senate Bill 1309, which Bridget mentioned earlier, and Robert Park with American Cancer Society's Action Network has been leading that initiative in Sacramento. We're supporting that effort. We are bringing together our lobby team to help put a voice behind that and work in connecting partners to engage and really advance the message with our policymakers in Sacramento. That's what we do. We've had conversations with whoever we can find an alignment with and just let them know about it. Let them know that their voice matters. And if they can engage and lend their support, that's what we need. It's the more voice out there, the better. If your organization is interested in legislation like this is an example of a policy where we can bring together a forum and get behind. And so this is just, again, one example of a piece of legislation that has garnered a lot of support, but we'll also need your voice to lift it up. And Senator Rubio has been such a great champion of lung health and really is just so well respected in the community and in her leadership in Sacramento. I'm very lucky that she is the sponsor and the author of this legislation. So what I wanted to also shout out is the Lung Health Advocacy Day that will be taking place on May 18th. So I think I've probably spoken to most of you about the event, and a lot of organizations, if have already signed on to be sponsors and show up, be there. But we'd love to have, we're just a convener working with our partner Breathe Southern California. Gilmer's here. If you want to learn more about the event, Gilmer's helping coordinate some of the signups and working with all the organizations that want to participate, meet with legislators, be part of the program. Dr. Cummings was able to be there as well, and she'll be speaking and meeting with the legislators. And we're really focused on legislative leadership, as well as the committee chairs, in making sure that we continue that momentum for the Senate Bill 1309, as well as other policies you want to elevate. So if your organization has or your government affairs leads, if you can please alert them about this May 18th day, Advocacy Day, we'd love to have them there. Participate and engage and share their voice. So that is kind of my highlight for what I wanted to talk to you all about. I believe that is what I wanted to cover. If you have questions or want to learn more about our work in lung health or the Advocacy Day, we're here to chat about it.
Any questions?
Thank you.
Thank you again. So we've now come to the part of our day where we're wanting to move into action, and I'm really excited to invite Dr. Loretta Arance and her team to lead us in the next session, which is focused on from evidence to action, scaling what works in navigation and screening promotion. So I'll turn it over to your team. And I seem to have lost my, oh, well, okay, I do have it. So they represent the City of Hope Lung Justice and Equity Lab. And what they're going to do with us today is facilitate a discussion and synthesize key takeaways from the symposium. So I'm going to tell you about the mission of the lab, but I'm going to ask them each to introduce themselves. But let me start by saying that the lab really focuses on clarifying the link between structural inequities, adverse social determinants of health, and lung cancer outcomes, biology, and screening practices, really for the purpose of transforming the narrative about why marginalized groups have worse lung cancer outcomes. So I'd like to welcome the members of the Lung Justice and Equity Lab to the stage and invite them to introduce themselves. There's a microphone.
Hello, everyone. My name is Amna. I am a research project manager at City of Hope at the Lung Justice and Equity Lab.
Hi, everyone. My name is Isatu. I am a clinical research associate, actually working in Dr. Arunce's lab. Yeah.
Hi, nice to be here. My name is Wendy. I am also a clinical research associate with one of Dr. E's labs.
Hi, everyone. Thank you all so much for being here. My name is Faith, and I am another clinical research associate with Dr. Arunce's lab.
I can start us off. Thank you, everyone, for being here today with the last session of the day. A huge shout out to all the speakers who are here today to present their research and all the different initiatives at their institutes. And a huge round of applause to the Choices Lab for putting all this together today. We will go ahead and start off by summarizing the event from today, and then going into some action items, and then some discussion from the audience. So I'll hand it off to Wendy and Isatu.
Am I just talking? Okay. Okay. Hi, everyone. Thank you, Amna, for that amazing introduction. We all heard a number of great talks today, and we broke it down into some common 3 themes that we saw across the talks that we saw today. So one of the first ones being that there are multi-level barriers to lung cancer screening. Something that was mentioned across a number of talks today was that California has one of the lowest lung cancer screening rates. I believe we are neck and neck with Nevada at 1%. We broke it down on 3 levels: the patient level, the provider level, and the system level. On the patient level, we found that there is a lack of education surrounding lung cancer screening. There are also a number of other barriers, such as the transportation. I know Zul mentioned that within LA, transportation can be very difficult. There are also socioeconomic barriers as well. In terms of the provider level, there are a number of competing interests within primary care, the lack of time, the lack of knowledge within provider education as well. Something that was also mentioned was that we could educate patients all day, we could educate people all day, but one of the main issues is the systemic barriers. You know, it was mentioned by Dr. E about the upstream factors. There is restrictive lung cancer screening criteria, whereas smoking is considered one of the primary criteria to allow someone to get a lung cancer screening. And then there's also fragmented care, where there are different gaps within. For example, there was mention of the deserts within LA, the pharma deserts, also the lack of communication between radiology centers or clinics and hospitals. And so yeah, that is one of the multi-level barriers to lung cancer screening. I will hand it off to Wendy to walk us through the interventions and a little bit more about what was explained.
Thank you, Isa. Building on the barriers that were just discussed, several key interventions were identified to help improve access to lung cancer care. One of the major focuses is improving access through multiple levels. So this is through patients, community providers, and policymakers. Some of the programs that we heard about was the American Cancer Society. They're doing work to expand lung cancer screenings and education to help increase early detection, particularly in underserved communities. One of the programs that really stood out to us was the ACS Cares, which is a mobile app that can be used as a resource for patients with cancer as well as caretakers to help provide them with resources in their care journey. With this being said, there is also policy that we should support in order to reduce the financial burden that could be incurred for patients who may be eligible but are not getting lung cancer screenings due to the financial cost that is associated with receiving those services. Another important intervention is improving communication with healthcare systems. We heard about a bidirectional messaging program that is used within EPIC to help facilitate the communication between the care team and the patients and help engage patients more as well as support them in their care journey. And so together, these interventions that were discussed today help demonstrate that addressing barriers requires coordinated care across teams and their communities. I'll hand it off to Isa to talk about the last one.
Thank you, Wendy, for that concise and beautiful summary on the different barriers. The last thing that we noticed was the multidisciplinary collaboration that was honestly emphasized through a lot of the talks. This idea that improving lung cancer screening takes a collective effort. And so what we noticed was that, there was this emphasis about collaboration across multiple stakeholder groups. There was the example of the American Cancer Society coming together with Cedars-Sinai, and then also this emphasis on working as a united front, right? That working as a united front will allow us to create lasting change. And then also, there was this beautiful reflection from Dr. E again, I'm biased, about the North Star, articulating the problem and being very clear about what our problem is, but then also aligning the forces, the different sort of the different sort of expertise that we're able to come to and aligning our forces strategically around it. There is also the shared goal and the shared benefit as well. There was a question that was asked about, sorry, awkward, ignore that. There was a question earlier about what would it take for funders and payers to be able to buy into this, and there was the beautiful reflection that with dollars saved, there's also lives saved. There is a financial benefit to increasing lung cancer screenings, that is way more cost effective. It's better to catch lung cancer rather than having to focus on treating it. So now, with all of those themes that we shared with you, we will hand it off to both Amna and Faith, who will lead us from the evidence into action. Thank you.
Thank you, ladies. So I want to thank you all for your participation today throughout the entire symposium. You've all been adding words to our word cloud just to express the things that you've learned from today. And I'm just going to call out a few of the words that were prominent in all of your submissions. First, a big word that was prominent is informative. I believe we all learned something today. We're all taking some action items with us today. Next word, action. There were a lot of action items that we talked about. Screening. I know throughout the day we were talking about lung cancer screening and just screening in general. Navigation, patient navigation. Collaboration, I think, is also a big one that we talked about today. How can we all work together to increase patient navigation, lung cancer screening for the patients, and just to make healthcare overall more accessible, inspirational. I'm glad you all were inspired by the talks that we had today. I was inspired. I got a lot of action items out of this and a lot of things I need to go and do and push the action forward. Billing, metrics, prevention, and I think throughout the entire symposium, we all just learned so many different things today, and we want to just thank you all for participating in this word cloud. Next, we wanted to talk about a few of the action items that we personally are going to take out of the symposium today. So how do we go from evidence to action? Regarding navigation and screening, one of the action items that we had was just outreaching and connecting with policymakers as to how we can create this change for navigation and screening. So we have a little screenshot there of how you can find your California representatives. And if you're from other states as well, I believe we can just all go on Google, look for who our representatives are, talk to the legislatures, and see how we can make changes system-wide. Secondly, using the tools that were presented today. I know we all learned a lot of things from today's sessions, so using those tools that you've all learned today to go from evidence to action. Specifically in the navigation format of this, the first evidence to action item that we had is looking into how we can go from automation navigation to AI navigation. I know in the beginning we talked about the difference between automation and AI navigation and how currently now we're looking at automation navigation, but how can we push that change towards AI navigation? Since we know technology is advancing every day and AI is becoming more popular, so why don't we use it to our advantage, specifically for lung cancer screening and navigation? Secondly, education around navigation reimbursement practices. So how can we reimburse our navigators for the work that they're doing? How can we reimburse the physicians for the work that they're doing? Because once we get the money, that'll get the motivation to continue doing the work that they're doing, right? Thirdly, just community-based partnerships. I think one thing that I took out from our later sessions today was Zoe's presentation on faith in action, the item that they're doing in Koreatown. I think that's an example of a good community-based partnership that's happening, and we can create more of these partnerships to relate more with our community. Specifically for lung cancer screening, we're looking at lung cancer mobile screening. How can we support that initiative? How can we all come together, collaborate to support that initiative, or even create more of those initiatives in other places around California and just worldwide in general? Secondly, supporting efforts to expand lung cancer screening criteria beyond smoking. I know we talked about how now we're all discussing how lung cancer is not just for people who smoke, but it's for everyone. So how can we support efforts to expand that criteria beyond smoking? And lastly, participating in ongoing initiatives like we've heard today. And now we want to hear from you all. What are some action items that you all are going to take away from today's symposium? Don't all speak at once, please.
Well, first, thank you. I mean, that's an amazing amount of work that you all did today during the course of our symposia. I'm really interested in the reimbursement practices for navigation. I mean, I think, one of the, I'm recalling going to a conference for the ACS Navigation Capacity Building Initiative, and that was probably the first place where I heard about systematic efforts that were being made to implement reimbursement for patient navigation, and sort of thinking about that as like credentialing and then the reimbursement that goes along with that. And I really feel like, the landscape is changing, because now that it's something that is reimbursed, that CMS has endorsed as a reimbursable service, I think there's a lot of important opportunities to learn about how we can activate those within our healthcare systems, because I think that is, one of the important opportunities to, one, create a financial incentive and to build long-term sustainability. So that's one thing that I'm committed to doing that. We're doing it now within the Ralph Lauren Center, but I think we can think about that, within all of our different clinical settings, is how, how we're thinking about that, and if there's something that we can do collaboratively to learn, first of all, but then also figure out how we can, adapt and implement across our different healthcare systems.
Yeah, thank you so much for bringing that up. I know that brought to mind the sustainability aspect that we talked about earlier. Like, how do we keep these programs sustainable? And I think money and finances is such a big aspect of this. So getting that reimbursement program started and all the different networks and all the different programs, I think it's a good first step. And this is the first step, discussing it, having the conversations about it. Any other action items that you'll be taking away from today? Yes.
Thank you. I think one that we can all take is disseminating the RFA that was talked about this morning from the California Lung Cancer Coalition to, again, build that foundational evidence, California-specific evidence for, future directions in lung cancer screening. And in the meantime, making sure that there's so many notes and takeaways for, just implementation of lung cancer screening within the current criteria.
Yeah. Thank you so much for bringing that up. I think we have another hand.
I think one of the things, working with AstraZeneca as a manufacturer, right, to come into a market to hear all the success, right? We do hear about some of the work that's being done, but how you could replicate that into other markets. So there wouldn't be an action item other than something for us to take away if we take it back to our headquarters, or we take it back to our markets and say, how could we replicate what's happening in California? When you give these very well-known systems that are working together, it's very inspiring, and you can see the impact that it's already happening. And so there are markets that are challenging and have challenges. And so I just say that's, for me, it would be more of a takeaway.
Yeah. Yeah, that's good, because that's why symposiums like this are important. This is where we get to learn, collaborate, and learn from our peers, and we can take those things back to our own communities and implement those things that we've seen are successful. Yes.
I want to go back to navigation. We first heard about navigation decades ago when Dr. Harold Freeman did the first study in the Bronx. And we're still talking about navigation, and a lot of health systems have not put effective navigation into practice. So this was the first time I heard about the Ralph Lauren program and the research that's being done here, and the development of a practice that works, that's sustainable, that's high quality. So one action item I'd like to propose is that we keep talking about navigation so that we learn from what's happening here and we can spread it to health systems across the region, because serving LA is unique. I mean, there's so much diversity in LA, and I think that we're able to create something interesting here and spread it. So I'd like to say that we create a learning collaborative, or we create something that we can keep this conversation about navigation alive.
Yeah, I agree. Collaboration is key, and just like continuing the conversations, like you said, about navigation so that it doesn't die down. Let's keep talking about it. Let's share it with others, so that not only is it a California initiative, but it's also statewide or outside of the other states too.
Yeah, thank you. And I just want to maybe double down on what you just said, Zoel. I think there's a real need. So first of all, great job, guys. Absolutely great. And I really appreciate the summary. And I do hope that we can create like real tangible action, because I think to your point, Zoel, like, Dr. Freeman in the 90s started, this conversation, and we have so much evidence, and yet and still it's not standard. It's not really standard throughout our systems, right? And so the question is, okay, so we continue to have a conversation, but what is the thing that gets us to change, so that we're actually doing this more? And I don't know if that is, and I say this about a lot of things, but maybe here we could potentially do it, is like articulate what the return on investment would be for our systems if we did this well. Like, what would it mean, right? Like, so, because it's always, there's some investment always, right? But, maybe with the Ralph Lauren Center, we show what that ROI is and then take it back, or we, but I just think that we have enough data. We've been talking about this long enough that there should have been a change by now. And so my question is still, why is it why are we all collectively still so behind in this space? And if anyone has an answer to that, please let me know. But that,
Yeah, I mean, I'll just echo and amplify a couple of things. I mean, I think, with our, I think your point is well taken, because we do have to demonstrate return on investment. And that's one of the things that's sort of built into our program at the Ralph Lauren Center. We are able to show, with this amount of investment, this is, these are the outcomes. And I think one thing that we've been talking about is, starting a chapter for AAON, a regional chapter, which will give us a space, a mechanism, a venue to talk about these issues and to continue to work together to address ROI, address sort of standardization. We're really wanting, again, with support of AstraZeneca, wanting to understand, the metrics for navigation that pertains to social determinants of health. So we have some of that initial sort of support, which I think will continue to grow. But so all those is to say, those are some of the immediate next steps that we're taking, and I think we will continue to take those through, the programs here, but also the regional program through the Los Angeles Lung Cancer Coalition and Healthy Lungs California. So those are really important mechanisms, I think, that infrastructure that serves to convene and sort of amplify and integrate. So if anyone's interested in the Lung Cancer Coalition, please let either me or Alexa know, because we are happy to have folks join.
Yes.
So funny enough, Trish and I were having this exact conversation this morning about alternate ways that pharma can actually help in the ecosystem space, other than just, through legislative efforts, through, grant money, et cetera. And so this was one of the things we were talking about is, and I hate to say it, but like all the work we do, it's a business, right? So when you're talking about return on investment, I know it's uncomfortable to talk about, but that's the reality. And so, and what we're talking about is funny, even I leaned over and I said, a lot of what we're talking about too is marketing, in a sense, to patients, because you're trying to get them to come in and have an action. And so the bottom line I was trying to say is that this really confirms the point of like, the nice thing about what we do is we see the entire country, and we see all the different organizations who are doing similar things. We can find the ones who are doing it great. We can find the ones who are doing it scrappy. And we can help convene and bring those partners together to say, let's learn from each other. And then also when it comes to bringing the tech companies to the table too, because they're coming to us and we're like, why aren't you going to the healthcare providers, right? So we can also help bring that to the table so there's a real rich discussion on how can you benefit your business, because that's truly what it is. And the patient, obviously, but just trying to say like reimbursement's really key when it comes to running your business.
I actually have something as well. Can I interject? I think related to the conversation, I know I've been the microphone passer around, but I have something to say. I think kind of centered around the conversation on return on investment. I think Patrick kind of alluded to this earlier, but I think we really have to think creatively about who we have in our spaces and who are doing these types of analyses, because sometimes I think when we're looking at certain metrics related to return on investment, when you're looking at things like long-term quality of life, related to cancer care, outcome, survivorship, it can be really difficult sometimes to kind of incorporate that into cost-effective analyses and to show that there is a return on investment. So I think that we also need to think creatively about how we do these types of analyses to show value. And I think somebody else said, I think it was Dr. Cummings as well, she just said, that stories are powerful, but data is even more powerful. And I would go even further and say that coupled together, they're extremely powerful. So I think that we do need the data, but we need to continue, like Faith said, to keep having the conversation around patient navigation. And I think part of it will be data-driven, but part of it will just be us in the room advocating for patient navigation, the stories that we see, and really getting leadership to understand what we're seeing on the ground. So I think that the two will be powerful together. With that, I will go back to my role as microphone passer around.
I can take if it's okay, I have the next mic. Just as a action item for me and sort of what I heard today, and it was a reminder in particular as you were talking about the work that's happening surrounding COPD. I'm a pulmonologist. I direct a pulmonary rehab program. I deal with patients who come with lung disease all the time. And that was kind of how I started into the space of lung cancer screening, realizing the gap that many of my patients have not been screened. It reminded me of how important it is that we're not just working together in lung cancer screening, but we're working together across multiple areas. And there are a lot of resources in breast, in colorectal, in prostate, whatever that it may be. And just being able to either teach our navigators to be able to cross various lines so that we're using our resources more efficiently. Because I don't think that there is a lack of availability of those things in more mature screening program. They exist, but they're just being in that space. And it's really reassuring to see what breast is doing in terms of removing some of the barriers as far as the copays, which is a huge thing when it comes to patients. When they get one screen for free, the follow-up is not free and they're not going to get it done. And so putting it all together, crossing various either screening or disease processes and putting it together is kind of reminder for me as an action item to take that back and try to see, can I incorporate things with other organs and other disease processes so that we can capture the most number of people without having to come up with a new person or a new role or a new FTE. Use the ones that are already in existence to help also lung, which is ultimately is going to impact the survival of that same group of population anyway. Thank you.
Thank you.
I was just gonna piggyback a little bit in terms of the return on investment as well. I was just thinking that we have already the information, we have the data, we know that preventing will technically improve and save long-term. We just need to focus on finding a team that get the data that is already published, to compile it, and not only the economic benefit, but also the outcome, the health outcome that can be done throughout the cost-effective analysis, and connect with payers, see what the payers are focusing more, and try to somehow connecting the dots in a way that eventually it will not be only used for lung cancer screening, but also for other type of cancer screenings, because at the end of the day, will help to save more at long term. Maybe at this short term, we will not see it, but that's our job as clinicians, marketers, and policymakers to bring that to the payers at the time of getting it approved or covered. So that's what I want to say, and hopefully eventually it's included. Thank you.
Thank you.
Good evening. I'm Pastor JJ, known throughout Los Angeles County as that grassroots leader that has those connections and communications with all inclusive in our communities. It's great. We can have the best ideas in the world, but if we don't do the outreach, if the outreach is not there, it's just not going to happen. I worked with Saul over there for 30 years ago, and we had the conversation. It was great, but if we have to put the action behind that conversation. And how do we do that? Is we need to get the outreach. A lot of folks don't even know when you start talking about that anything like this exists. However, there's so much great work going along with what we're talking about here across the country. But somebody just said connecting the dots, unification, and then once we unify, let's get the information out to do the outreach, get it out to those who can actually move this forward.
Yeah.
So that's fine.
Thank you so much for bringing that up. I think that's a great way to round this discussion up, is that action item that you just said. The outreach is a really, really important part of what we're doing. It's like getting the information out there to the patients. A lot of them just don't know that these resources are available to them. So let's continuing these conversations, the collaborations, and the outreach part of lung cancer screening and navigation. Thank you all so much, and thank you.
Well, I'm going to bring us to our conclusion, but I really just want to start that by saying, I'm so grateful for all of you for coming, but really, you heard from the boss today about who's making it happen, so thank you to my research team, Trista, Diana, Alexa, and Kelsey, for making this a wonderful, wonderful event. And Reverend JJ, I think you summed it up really nicely. This is an event for us to connect the dots. We've done a lot of important things to connect the dots here. We'll continue to connect the dots, but also to create a beautiful landscape and picture that is one where we're free from cancer disparities, particularly as it relates to lung cancer. I'm sorry, Oh, okay. So thank you again to our sponsors, AstraZeneca, our colleagues, the Ralph Lauren Center for Cancer Prevention through the Ralph Lauren Corporate Foundation, City of Hope, the California Lung Cancer Coalition, and the Keck School of Medicine. We're so very grateful for your continued support and collaboration and partnership. So we will bring our conversation to a close in this setting, but look forward to our ongoing discussions throughout the year. And you won't get rid of us. So we'll be back. We'll be here. We're here. Thank you.